welcome everyone. I'm Dr. Omar Shakoree. I will be your tutor for today's class. We will discuss today the assessment of abdominal trauma according to Australian guidelines. I am accident and emergency surgeon and co-manager of emergency department at As-Salam Teaching Hospital. Are you ready to start, please? Say yes or no. Yes. Okay. So, what are our aims for today's class? Our aims is to know the types of abdominal trauma, the first aim, and the second is to know how we can manage each type of those abdominal trauma. And we want the most important part of this class for you is the early actions in abdominal trauma. This is your job in the hospital. And we will discuss some notes about solid organ injury. So, types of abdominal trauma. How many types there for abdominal trauma? Just elevate the hand and say it. Yes? Okay, thank you. We have two types, penetrating trauma and we have the blunt trauma. We will start by penetrating trauma. Just before that, who can tell me which is more common? Is it the blunt or the penetrating? Blunt. Of course, the blunt is more common. But during war that happened in Mosul, the penetrating were more. Okay, shell and bullet injury and blast injuries. Okay, this is picture for penetrating trauma. Okay, this is middle-aged male with a stab wound in the abdomen. The question is, what is next? This is the patient. You receive this patient in your emergency department. What you will do for this patient? Tell me the first step. What you will do? This is in front of you and you are the doctor, the rotator doctor. You have to take the action, the first action. What will be? Stop what? This is correct. The first step, the most important step in any penetrating trauma, not only in the abdomen, try to stop the bleeding. If you have obvious bleeding, try to control this bleeding. This is the most important part in ABC. Nowadays, they call it C, small c, control of bleeding, then A, B, C, D, E, F, F, F. Okay? So how we will stop this bleeding? By what? The first step is to apply direct pressure. For the abdomen, we cannot do this. Okay? Please note that never do blind clamping for any arterial bleeding or use of tourniquet. Nowadays, we cannot use it. This is not allowed to use it, even in the hospital. In the hospital, tertiary hospital, we need to take action, never to do tourniquet in tertiary hospital. Also, if you see this object here, please never try to remove it in the emergency department. Any object like a knife in the chest or a knife in the abdomen, never to try remove it in the emergency department. This should be removed in operating theater under GA. Okay? What is next after we control the bleeding? Okay, so circulation to large bore IV lines plus give fluid and blood. What is the best fluid to be given in abdominal trauma patient? The best fluid, we are not speaking about blood now. Normal saline. Normal saline. Ringer lactate nowadays is less in use. We use ringer lactate for preparation of abdominal surgery patient. Because it's not because the ringer lactate is the best. The best is Hartmann solution. We don't have Hartmann solution, so we give ringer lactate. Like patient prepared for appendectomy, he's in the emergency department. What you will give, the best is to give ringer lactate. Okay? What is the type of blood in this situation? The best blood? No? No? Best type of blood, not best blood group to be given. Packed RBC. Packed RBC. Unfortunately, we don't have the packed RBC, but I want you to know that every patient with a trauma, and when we will transfer blood to him, we have to give packed RBC. 1 pint packed RBC plus what? 1 pint RBC plus what? How much plasma? How much? One plasma, 1 pint of RBC, 1 pint of platelet. Okay? If you suspect organ injury or rupture or severe internal bleeding, we will do exploratory laparotomy. And we will discuss this also. Any question until here, please? So let's back to step. If we have penetrating injury, what we will do if we have penetrating injury to the abdomen? Number one, we will try to control the bleeding. By what? By applying direct pressure. This is not occur in abdominal injury. We have to know that never to remove the foreign body from the abdomen in the emergency. We have to remove it under GA. Number two, we will establish 2 large bore cannula, and then we will give a fluid. How much fluid we will give? I know that you didn't take the hypovolemia until now, the shot. But from your knowledge, how much fluid we will give for abdominal injury? Any suggestion? Up to, we can give up to 3 liters. Okay, but not more. After that, we have to give blood. Remember the C, A, B, C, D, E, F, 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 and I will explain it later. Indication for emergency laparotomy in penetrating trauma patient. Number one, if you have penetrating injury plus vitally unstable in abdominal trauma, when we say, just remember this, in a trauma, when we say that patient is vitally unstable, this means the patient has hypotension. Okay? To make it easy, any patient with a trauma and hypotension, this is the patient of vitally unstable patient. Okay? So if we have penetrating abdominal injury plus hypotension, this is an indication for emergency laparotomy. If we have peritonism means rigid abdomen, toxic patient. If we have free air under diaphragm, also this is indication for intervention. If we have evacuation is the exploration of intestine through the wound of the abdomen. If we have gunshot wound transversing the peritoneum, this is indication. This is very common in the war to be seen by gunshot and by shell. So this is also indication for emergency laparotomy. I don't want you to memorize those. Those are not so important. The idea is to know if we have penetrating abdominal injury and unstable patient. This is the indication. Free air is easy to know. Of course, if you have evacuation, this is an indication. And gunshot through abdomen, this is also indication. Any question, please? Clear? Okay, before jumping to blunt, who can mention the steps, all the steps that we discussed? Who can say them? From the treatment. Muhammad.
Try to control blood.
Okay.
IV line to large bore IV line.
Okay.
1 pint of blood, back RBC.
Fluid before it.
Fluid, normal saline.
Okay.
Up to 3 liters can be given.
Okay.
1 pint back RBC, 1 pint plasma.
And remember the ABCD. Okay. Thank you. Okay, blunt abdominal injury, which is the most common. This is occur after especially car accident or fall from high, and those are boxing accident. It's the most commonly affected organs in a blunt abdominal: spleen plus liver plus kidneys. And the spleen is the most common one. What are the clinical pictures for internal bleeding? Number one, I mentioned it before, the hypotension. What else? Yes, what else? Abdominal process. What else? Fracture. Internal bleeding, not in the chest. Tomorrow you will take, after tomorrow you will take chest injury. Peritonitis, hematuria for kidney injury. Okay. Hypotension, tachycardia, abdominal wall ecchymosis, plus abdominal rigidity and tenderness. Those are the cardinal features for internal abdominal bleeding. If you have hypotension, this is number one, the most important one, hypotension. Number two, the tachycardia. If there is any ecchymosis surrounding the abdomen, in the area of abdomen, this is also give you suspicion of internal bleeding. Plus, if there is abdominal rigidity and tenderness, this is also a cause for, this is also mean internal bleeding. What are the investigation in blunt abdominal trauma? Okay, which patient you will send for fast? Okay, let's suppose yesterday we received in the emergency department a 32 years old man presented with RTA with head injury, and the patient received in the Al Jumhuri hospital, then transferred to Ibn Sina. Ibn Sina transferred the patient to Al Salam. This patient, when presented to us, he was unconscious, okay? And we don't know what's inside the abdomen. We examined the abdomen. His abdomen was soft. His Glasgow Coma score was 9/15. So, what is next in that patient?
CT.
Okay, CT is not available. What you will do? Why they sent it from Ibn Sina to Al Salam? They want the opinion of general surgeon to say that the abdomen is free, no need for intervention. So how you will help the surgeon to detect if this is positive abdomen or abdomen with trauma or negative abdomen? This is unconscious patient. He cannot say that I have pain in the abdomen. You don't know if he has pain or not. You don't know that this patient rigid abdomen, because he cannot explain this, he cannot express this, and he is unconscious and the abdomen was soft. Vitally, the patient was stable. Vitally stable patient, he is not hypotensive. Okay, he is not hypotensive. Look, for any abdominal trauma, for any, either it's penetrating, no. Either it's penetrating or it is blunt trauma. I have just two options. Either I will send for fast, either I will send for CT. But fast, send the patient who is non-stable, who is hypotensive patient, send for fast. Stable patient should be sent for CT of abdomen, CT with contrast, not plain CT, CT with contrast. Okay, this is just the trick. Stable patient, send it for CT with contrast. Non-stable patient, send this patient for ultrasound. So, focus assessment sonography of trauma. When to do it, please send the patient who is non-stable, and just imagine you have not to send. The ultrasound should be in the emergency department and should be in the trauma room, so you can do fast by yourself. So send the patient who is non-stable for fast. What is the value for fast? The fast focus assessment sonography of trauma can detect hemoperitoneum, pericardial effusion, and intraperitoneal fluid. If you have positive finding, just imagine with me, this is unstable patient who have positive fast, this is indication for exploratory laparotomy. Clear, please? Okay? CT scan with contrast. Send the stable patient for CT scan with contrast, and this is the best to detect the liver, splenic, and kidney injury. Now there is a question, and this has happened always in the emergency department. You receive unstable patient. You send the patient for fast. Fast come to you with negative. Fast, normal, no free fluid inside the abdomen. What you will do for this patient? Again, he is unstable. He has trauma, car accident. Unstable patient, you send for fast, fast come to you negative. What you will do in this situation? We do resuscitation before doing fast. Unstable. You cannot waste time. CT with contrast will take 20 minutes. No. What is the best action for this patient? No. No, not surgery. No. This is your job. You have to know this trick. If you have unstable patient, he is now in front of you. This is our patient. He is unstable vitally. I did ultrasound, bed examination, ultrasound in the emergency. Ultrasound was negative. Consider other injury, other parts than the abdomen. Okay? Maybe the hemorrhage is inside the chest. Maybe there's diaphragmatic injury and causing hemothorax and pneumothorax. So consider other injury. Okay? So a negative fast in hemodynamically unstable patient reliably exclude the abdomen as the source of hemodynamically instability, and if fast result was negative, other causes of hemodynamically unstable patient must be considered. I remember one case in 2014 presented to Al Jamhuri emergency department with car accident. At time of presentation, vitally he was stable. Then this patient admitted to emergency inward patient. After he was 40 something, I don't remember the age exactly. After 2 hours, the internal doctors come to us, tell us that the patient is dying. Okay? Fast was negative in that patient. Unfortunately, that patient has a fractured femur and he lost a lot of blood in the thigh, and the patient, after resuscitation, the patient passed. So keep in mind that there is other injuries, not only in the abdomen, in hemodynamically unstable patient. Okay? Any question until here? Okay. What is the treatment? The treatment of blunt abdominal injury. Again, we will discuss the C, A, B, C, D, E, F, F, F. Okay. C is control bleeding, A is airway, and B is breathing. C is circulation, D is disability and immobilization. Exposure, what about the F? Who know what are the F, 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 F? No. No, F. No, it's part of circulation, the fluid. No follow-up. It's part of circulation, the fluid. One of them is Foley's catheter. What else? One F is don't forget the Foley catheter. No, it's part of disability, immobilization. What else? Okay. Foley catheter. What else? Let's see. Finger examination. Either per vaginal examination, either per rectal examination. This is part of multiple trauma patient. You have to do finger examination. Don't forget that. Plus fast. Fast is now part of the ABCD of the patient multiple trauma, especially the abdomen. The last F is fentanyl, not morphine. Usually we use paracetamol, diclofenac, we use tramadol, which is available here. Outside, they are now using fentanyl for trauma patients. Fentanyl is one of the opioids that is 100 strongest than the morphine. So just imagine the patient will be euphoric after receiving this medication. Fentanyl is available in our locality, but it's just with the anesthetic team. Okay? Any question until here? Okay. So this is diagram show you that the blunt trauma, either it's not clear here, either it's unstable, either it's a stable patient. If unstable, do fast. If fast, come with the free fluid, yes, then exploratory laparotomy, it's the same. If no, just follow up with the patient. Indication of emergency laparotomy in blunt trauma. Again, I don't want you to memorize them. I want you to know how we are processing the patient when we do fast, if it is positive or negative, and when we do CT scan, if it is positive and negative. Peritonism, free air, significant gastrointestinal hemorrhage, hypotension patient with positive fast, increasing abdominal pain, and high-grade solid organ injury. Early action in abdominal trauma, and this is the main point of your job. The early actions, what you will do. You are the doctors who are receiving this patient. You are the first doctor who received this patient. So what you will do? This is regarding the management. I want you to be the leader of the situation. I want you to be the leader of situation. So, what you will do? You will gather the vital information from the notifier or the witness of that condition using the mnemonic, ample history and missed for management. What I want you to do when you are receiving trauma in general and specifically for abdominal trauma, I want from you the ample history. Do you know what's ample history? Okay, who can tell me? What's A? What's M? Medication. What is L? What is E? Thank you. What about the missed? So A for allergy, M for medication, P for past history, whether surgically, medically, past family history, and last meal and event. Those are important points in the history of traumatized patient, abdominal trauma or other traumatized patient. What about missed? Do you know it? Okay. Missed is mechanism of injury. Injuries found or suspected. You receive this patient, you have to give me yours as a senior. I want you to tell me that what you suspect you receive the patient. Do not just be a writer for follow-up and for investigation. No, your impression is important for the older one, the older doctor who is permanent or senior. So we want you to tell us what you suspect in this patient. You suspect chest injury plus abdominal injury, you suspect pelvis injury, you suspect other injury, head injury. This is very important. So injuries found or suspected, you have to mention it for us. Also the signs, the vital signs, you have to know them, and the treatment given. So if a patient presented to emergency department and the permanent come to you to the emergency department, you receive the patient, you send the patient for x-ray. Now the patient is not in the emergency, but your permanent come to you, tell you what is the patient. Please do not just say abdominal trauma, I sent for x-ray. No, be more precise. Say that I have received patient, he was not allergy, the mechanism is a car accident, he was the driver, he was the passenger, in front passenger, he was the back passenger. I want all this information, all this give impression about the type of accident. He was hit it while he walking on the street, This is also important, okay? And I suspect that chest was injured. His chest was a little bit paradoxical movement, and signs was vitally stable or non-stable. I will focus on the blood pressure. Why I am focusing on the blood pressure always when I say vitally stable or non-stable? Why? Because you will take this in degree of hypovolemic shock. The first, second, third, fourth. The hypotension starts from the third degree of shock. Hypotension when the patient lost more than 1,050, 500 cc of blood. So this is profuse hemorrhage. This is important that the patient, if has hypotension after trauma, the patient is in third or fourth degree of shock. So this is dangerous patient. Okay, this is number one. Number two, the first one is your job to take ample history and to do MIST for management. Number two, I want you to ensure that all the staff dealing with the patient has a gloves. This is simple. Just be sure that you and the staff that working with you wearing their gloves. Number three, if there is a trauma team, and there is a trauma team outside, but here just inform your permanent. Activate the trauma team, okay? This is number three. Number four, I want you, even the man who bring the chair, you have to ask them to come. So you can control all of the situation. Starting from telling the staff with you, wear your gloves, bring the trauma team, call your permanent, and set up the trauma bay to receive the patient, including equipment check, documentation. All of these you have to give attention about. Medication and resuscitation equipment. Also those, the equipment, the medications, resuscitation equipment, all of these available in the trauma room. Number five, and this is very, very important, especially in a trauma patient, you have to repeat your instruction to the staff. You are the leader. Don't underestimate your job. You are rotator doctor. You are leader in this situation. No one is above you. You are receiving the patient. You are the leader. So repeat instructions to all the staff and make eye-to-eye contact. There is misleading in understanding the information. If I want this nurse, let's say Ahmed, I want him to take care of the cannulation. So Ahmed, leave everything by eye contact. Ahmed, leave everything and please bring 2 large bore cannula and put it for the patient. Direct eye contact, so he will take it as seriously. Okay? I will repeat those again. Ample history and MIST management. This is what we wanted from you. Number two, wearing the gloves, all the staff. You have to ensure all the staff wearing the gloves. And you will call your permanent and trauma team. And you will ask the person who is responsible for taking a patient to come to the emergency department. Also, you have to have good communication with your staff and keep eye-to-eye contact and always repeat the instruction. Do not be lazy to repeat the instruction. They want this. We have to repeat for them. The staff, we have to repeat for them. Any question until here? I'm so happy. Okay. Now, solid organ injury, spleen injury. Spleen injury is the most injured organ in the body. The patient will be presented with left upper quadrant pain. Just keep this note with you. Any patient with left body trauma, fall from high to the left side, this patient is in danger of having solid organ injury. So keep this patient under observation, even if he is vitally stable. Why? Abdominal wall contusion, I will say this just a few minutes. left lower chest wall tenderness, left shoulder pain is referred from splenic hemorrhage irritating the phrenic nerve and the diaphragm. This is the important. Patient may be presented at first normally. The patient with spleen injury. Why he presented normal? Let's suppose that he has injury to the spleen at time of accident, but a thrombus formation stopped this bleeding inside his spleen. The problem is that this patient may present it after 7 days, up to 14 days. The patient may be presented with delayed hypotension occur after this thrombus dislodged. So just imagine, patient now presented with abdominal trauma, and he is okay. You discharge the patient, your permanent discharge the patient. After 5 days, the patient come to you again to the emergency department with hypotension. What could be the cause? Here, the cause could be dislodged thrombus from the splenic injury. There is spleen injury and there is thrombus occur at time of injury, so it stopped the bleeding, but after a few days there is dislodged of this thrombus and the patient has internal bleeding and presented with hypotension. I saw just one case in my life for this patient. Okay, patient presented after 9 days. So be careful, it's very, very dangerous to have delayed hypotension after abdominal trauma. Okay? How you diagnose the solid organ injury? Again, abdominal CT scan with IV contrast if stable patient. If non-stable, what you will do? Fast. Okay? What about the management? How we are managing the hematoma around the spleen? If vitally unstable, okay, directly laparotomy. What if vitally stable patient? What you will do? What you will do?
The small tear will try to switch out the ground.
Okay. Nice.
Large tear,
Nowadays, in Iraq, we are doing splenectomy. The surgeon do splenectomy for all traumatized patient with hematoma in the spleen. But outside, the stable patient put it in two different ways. If you have a stable patient and there is extravasation on CT, again, if a stable patient, we send for CT. CT show us extravasation. What they will do? They will do embolization. We don't have this facility in Iraq, neither here, neither in Kurdistan. If vitally stable, but there is no extravasation, so just the bleeding is within the capsule of the spleen, we can put the patient on conservative treatment. Okay, so make it easy. Unstable patient, directly we will take the patient for laparotomy. And if we have a stable patient in Iraq, if a stable patient and we send for CT with contrast and CT show extravasation, we will do laparotomy and we will do splenectomy. This is in Iraq because we don't have the embolization facility. Outside, extravasation and patient was stable, they will do embolization. If vitally stable but no extravasation, conservative treatment is enough for that patient. What about the liver? The most of cases liver injury heal by conservative treatment. Rarely we are opening the abdomen in cases of liver injury. Just if the patient, again, unstable patient, equal laparotomy. What about the kidneys? Usually the kidney injury is caused by blunt trauma and the patient will have hematuria, as Dr. Muhammad said, and flank pain, plus we will do CT with contrast if he was stable, and if unstable we will do fast. All still we are speaking about the same. If positive fast we will do laparotomy. The treatment, most of cases heal spontaneously if the patient was stable. Okay? Clear? Any question? Okay. Some notes about abdominal trauma. Please, the blunt trauma to the epigastric area causes rupture of which organ? Of course, causes rupture of stomach. Blunt trauma to the chest causes rupture of what? Aorta and esophagus. Stable patient sent for CT with contrast, unstable patient again sent for fast. If positive fast, you can send the patient, prepare the patient for laparotomy. Penetrating wound, unstable patient, even if you don't have the facility for fast, like a patient presented with penetrating wound and he was unstable, this is indication to do laparotomy immediately, even without the facility of fast. Any question? Enough? Okay. CT is not available. Nowadays, CT is available. In our locality, nowadays, CT in Al Khansa and Ibn Sina and Mosul al-Am available. So we will send the stable patient for them. But the problem is that it's plain CT, not contrast. So this is the problem. It will be not informative for the surgeon to give the decision. So sometimes if you have a stable patient with blunt abdominal injury, we will admit the patient for conservative treatment. We will depend if the patient deteriorated or the patient still vitally stable. If the patient start to be deteriorated and vitally unstable, we will do operation for him. Okay? Focus assessment sonography of trauma. Previously, when the hospitals were good, in Al Jamhuri there is a room for trauma, and it has the facility of bedside fast, and we as emergency doctor, we were trained on doing fast. So previously it's available. Now it's not available, and just a few hours in the morning and 2 hours in the night. You will discharge the patient, but you have to inform the patient that if anything occurred during these 2 weeks, please come back to the emergency department. This is the best option when discharging this patient. Okay? Any patient and you suspect splenic area injury and the patient is stable and every investigation is normal, you will discharge the patient. Tell him anything occur, come back to the hospital before deterioration. What else? Okay, thank you for today. We will take a break and then we will continue our lecture for wound management. This class will be available on my channel, Omar Shakoree, inshallah.